Bismillah ar-Rahman ar-Rahim. I will be talking on bifurcation stenting in non-left main lesion subsets. Bifurcation lesion is a critical lesion in major coronary artery adjacent or near to a significant branch. And the significant branch is defined by its area of distribution. Now, a brief about anatomy. There are certain factors. It has fractal geometry, and there are various components of bifurcation, which is proximal main vessel, the distal main vessel, the side branch, carina, and POC, which is the polygon of conference. Here you can see all those components: proximal main, distal main, side branch, polygon of conference, the bifurcation angle, which is angle of carina, carinal angle, and the carina itself. So there are multiple classifications available in the literature, but the Medina classification is simple, easy to remember, and most commonly used. Now in this classification, a number 0 or 1 is attributed to all the segments depending upon the presence or absence of critical, more than 50% critical lesion in all the segments which we have just mentioned. So for example, in the first arrow shape, this is critical lesion in the proximal as well as the distal main vessel and the side branch, and this is Medina 111. And similarly, we can label all these lesions. Now, beyond Medina classification, we have to divide this bifurcation classification into true bifurcation and non-true bifurcation. All those lesions which have a main vessel lesion as well as a critical significant lesion in the side branch, they are known as true bifurcation, and rest of them, they are non-true bifurcation. Now, there is a second most important distinction in the true bifurcation, which is about the simple true bifurcation versus the complex true bifurcation. And this depends upon this definition criteria, and it has major and minor criterias. And the major includes left main bifurcation with side branch lesion length more than 10 centimeter and diameter stenosis of more than 70%. Whereas in left main stem bifurcation, the lesion length should be more than 10 as in the left main, but the stenotic degree should be more than 90% as compared to 70% in the left main. And the minor criteria include calcification, multiple lesions, very shallow or steep angle, and the main reference diameter less than 2.5, the main lesion length more than 25, and thrombus burden. This is another illustration showing simple true bifurcation and complex true bifurcation. Now, if the side branch originates from a lesion in the main branch but has a normal is a normal vessel or has a stenosis of less than 50%, there is 2 to 4% chance of its occlusion. And this is according to the Nordic 3 and Cross and V-Resolve studies. Whereas if the side branch has more than 50% stenosis and arises from the main branch lesion, it may have low stenosis rate or occlusion rate, maybe in single figure if it is simple true bifurcation, and it may go up to even 20% if it is a complex bifurcation. So the worst outcome is acute versus long-term outcome is related to the plaque burden, calcification, and the extent of the disease in the side branch, and also on the extent of disease in the main branch. And in case of shallow angles, like if the angle is less than 45%, although it is easy to access, but there is more carinal shift in these cases, Whereas if the angulation is more than 70%, there is less cranial shift, but it is more difficult to re-access these branches. Now these are the different predictors which we have already discussed. They predict the occlusion of the side branch. Now after discussing these classifications, now we come to the treatment. Now there are two options. One is the provisional stenting technique, the other is elective double stent technique. Now provisional stenting technique is the planned one stent strategy in the main branch with provisionally pre or post dilating the side branch if needed and provisionally stenting the side branch if required. Whereas the elective double stent technique is a planned upfront double stenting technique. So there had been various trials and they have been comparing provisional versus planned two stent strategies. In early 2000, these were the three trials which described the comparison of these two main approaches, and there was no clear superiority of the double stent technique over the provisional stenting in these trials. These are the newer 10 trials which have actually discussed the different subsets of these bifurcation lesions. For example, for non-true bifurcation, the leave it alone is the best policy, particularly if the side branch is totally free of disease, which is Medina 110. And in this, even the cross-Korean trial in the Nordic study, actually they compared provisional leave it alone policy with provisional post dilatation, and the results were similar in both the approaches. And in true bifurcations, these trials like Perfect Korean, Nordic 4, European Bifurcation Club 2, DK Crush 2, they compared the provisional strategy with often with the ballooning side branch with two stent, and both the approaches showed similar results. There was no clear-cut difference in the acute and long-term outcome of the two approaches. Similarly, there are few trials they were done the left main, and that were also true bifurcations, and there too they could not show a superiority of two stent technique over the provisional technique. There are only two trials which are available, and one included the left main as well as the non-left main subsets, which was the definition 2, and the DK Crush 5, which included only the left main stem. Here the disease was, this group was complex true bifurcation lesions, and the upfront two stent technique showed the superiority over the provisional technique. So now there are certain questions which comes to the mind after going through all these classifications and the data. Now whether to wire the side branch or not, provisional side branch stenting versus upfront two stent strategy. In provisional, whether to pre-dilate the side branch or not. In provisional, whether to post-dilate the side branch or not. In provisional, when to provisionally stent the side branch after the main branch stenting. And in provisional, if stent is needed, what stent strategy should be used. And in two stent strategy, what is the best stent strategy. So even if you don't have to pre-dilate or post-dilate the side branch, it is often important to wire the side branch, whatever the type of subset of bifurcation lesion may be. The wire reduces the risk of side branch occlusion. I think I'm getting short of time. I'll have to quickly go through. So we have to wire all the branches, and if there's a critical lesion in the side branch, one may pre-dilate, and in the trials it was done in 40 to 65% cases in true bifurcations. And in after the main branch stenting, if there is a critical lesion or occlusion of the side branch, then you may go for post dilatation as well. But if the result is not good, if there is TIMI flow less than 3 or the critical stenosis, in case of left man it's more than 70%, in case of the non-left man subset, if it is more than 90%, it needs to be stented. And in most of these trials, the TAP technique was the most commonly used technique in these patients. So this we have just talked, and this we have already discussed. These are the mechanisms of occlusion of the side branch, which is plaque shift, geometric distortion, and cranial shift. And we have just talked about the provisional stenting, as I talked the criteria for the stenting as well as the technique. And if a person has a complex tube bifurcation, which is more than 90% side branch disease, with lesion length more than 10 and there's a calcification, these are the patients who should be taken for upfront two-stent technique, and the DK crush is the best technique according to the available data. These are the guidelines, and this is the guideline to how to decide about the selection of the balloon for the post-dilatation. And this is an example of provisional post-dilatation. I will just quickly go through. So this is the relevance of FFR in these patients. Most of the times, once we, if angiographically we see that the lesion is critical, but if you do the FFR, according to this data, if you just focus on this, the TAP technique is the most commonly done technique. In upfront two-stent technique, the DK crush is the best technique. Thank you very much.